Hello everyone, I am Ashwitha H Gamsa, Assistant Professor from the Department of Optometry, here to talk about contact lens fitting post-refractive surgery. To begin with the specific learning objectives, at the end of the session, audience will be able to list the indications of refractive surgery, corneal health and visual outcome, to describe on PK, DALK, DISEC, DIMEC, RK and LASIK, explain the contact lens fitting, mainly pre and post fitting assessments, mainly about soft contact lenses and RGP contact lenses. To define what is refractive surgery, it is defined as a correction or reduction of any refractive error including presbyopia by surgical or surgically assisted means. It aims to increase unaided visual performance, to decrease the reliance on spectacles and contact lenses, to increase sporting activities and performances, to increase the cosmetic appearance and to increase the self-esteem of the patient. So what are the types of refractive surgeries? We have penetrating keratoplasty, abbreviated as PK, deep anterior lamellar keratoplasty, Descemet's stripping endothelial keratoplasty, Descemet's membrane endothelial keratoplasty, radial keratotomy and laser assisted in situ keratomyolysis. To begin with the pre-operative evaluation, mainly as an optometrist, the general consideration that we do is age of the patient, stability of the refractive error for the past 6 months, previous contact lens wear history and how motivated is the patient are the main general consideration that to be considered. The exclusion criteria while considering for refractive surgery include existing corneal pathology, thin cornea of the patient which might be due to keratoconus, keratoglobus and many other degenerative conditions, progressive myopia, systemic disease with a collagen abnormality and abnormal corneal topography. To begin with the first surgery, that is penetrating keratoplasty, it is a surgical removal of full thickness of central cornea and its replacement with a human donor corneal graft. The procedure begins with a common graft size of 7.5 mm and the donor button is usually 0.25 mm larger than the host side. As we can see in the image here, this is a corneal button made, then the host button is removed whereas the donor button is being implanted here. The diameter of the donor button is usually 0.5 mm larger than that of the host button. This can be done either mechanically guided, manual or automated machine. Graft can be secured with either interrupted sutures or continuous sutures. Moving on to the indications for penetrating keratoplasty, the most common indications are keratoconus, bullous keratopathy, corneal scars and opacities, corneal dystrophy conditions or recurrent herpes. Moving on to the complications of penetrating keratoplasty, these are some early and late complications that are listed below. The early complications include flat anterior chamber, iris prolapse which can lead to increased IOP, recurrent epithelial defects, infections, primary graft failure, wound leak and raised IOP. Whereas the late complications include the astigmatism, glaucoma, recurrent corneal infections, graft failure, rejection and graft infiltrates. Moving on to the next procedure, that is deep anterior lamellar keratoplasty. In this particular procedure, the Descemet's membrane and the endothelium are stripped from the recipient's posterior stroma. Donor tissue is then transferred into anterior chamber. Donor tissue is unfolded and attached to the posterior stroma using an air bubble. The process is sutureless. As we can see in the image here, the Descemet's membrane and endothelium are being attached. The next procedure is Descemet's stripping endothelial keratoplasty, where donor material consists of endothelium, Descemet membrane and a thin layer of posterior stroma, compared to the previous procedure where we do not involve the posterior stroma. The visual recovery is better than the PK. The next procedure is Descemet membrane endothelial keratoplasty. Here only Descemet's membrane and endothelium are transplanted. Cornea is nearly normal after healing and the visual acuity has been improved up to 6 by 7.5 in 80% of the population by 6 months. But there is one drawback of this, that many cases have been found that there was an increase in intraocular pressure. The contact lens fitting after penetrating keratoplasty is sometimes necessary for adequate visual acuity. Typically, contact lens fitting begins 6 to 12 months after surgery following removal of the sutures. The fitting process can begin as early as 3 months for some patients who require contact lens for functional vision. Pre-fitting evaluation involves evaluation of central and peripheral cornea is best done in corneal topography. As we can see in the image here, we have corneal topography image, we have cool colors and warm colors, and here we have the values of the K values, that is mainly talking about the steepness and flatness of the cornea, which gives in 3 mm zone, 5 mm and 7 mm zone of the cornea. Post PKP, the contact lens fitting options are rigid gas permeable contact lenses with spherical back optic zone diameters. Usually there will be large amount of astigmatism that will be residual, that is mainly corrected using RGP contact lenses. Then we have piggyback contact lens system, where patients are mostly they will be feeling discomfort because of hard lenses. So soft lens is placed on top of that, RGP lenses are placed for better comfort in case of soft, whereas RGP can give a better visual outcome. Then we have scleral contact lenses, because of the sutures can extend up to scleral region. So scleral contact lenses are large diameter lenses which provides a optimum visual acuity. Then reverse geometry contact lenses, mainly if the resulting astigmatism is highly myopic in nature, then it can lead to the reverse geometry contact lenses can be of great help. Then soft contact lenses, mainly toric lenses are employed, and while employing a soft contact lenses, mainly silicone hydrogels are preferred because of high water content, which helps in better physiology of the cornea, which includes best oxygen permeability to oxygen, maintaining the corneal health. Then contact lens fitting is also possible at 3 and 6 months after the surgery. Then we have radial keratotomy. It is a surgical myopia reducing procedure in which a series of deep mid-peripheral radial incisions are made in the cornea to flatten its curvature. As we can see in the image, there are radial incisions are made in the cornea to reduce its curvature. Using a microscope, microsurgical instruments and a diamond plate, several deep incisions are made in the cornea in a radial or spoke-like pattern. RK flattens the cornea and reduces its power. This allows the light rays to focus directly onto the retina. Most commonly employed complications after RK are infections, recurrent corneal erosions, corneal edema, intersecting insections, and poor positioning of the optic zone, which might lead to decreased visual acuity. Moving on to the soft contact lenses. Soft contact lenses after RK has been seen to be successful. We use usually thin disposable lenses. Visual acuity results as they drape more easily over the new flattened corneal contour. Use of high water content lenses reduces the chance of hypoxia and reduces the chance of vascularization as well. Extended wear is contraindicated as the hypoxia inherent with this modality is likely to trigger vascularization along with the incision lines. The RGP lenses for RK patients requiring post-surgical contact lenses, they are mostly optically helpful. After RK, in which prolate sheet of cornea becomes oblate, centration always requires the use of large diameter lenses, typically 9.8 to 11 mm range. Usually when we prescribe RGP lenses, we start with the smaller diameter lenses, but in case of RK, since there are incision marks and the cornea shape changes into oblate, we might have to start with the larger diameter lenses. This is one of the example how a contact lens fitting looks like after radial keratotomy. You can see a incision marks here. The next surgical procedure is laser assisted in situ keratomyolysis, abbreviated as LASIK. LASIK is a flap surgery where the flap is cut into stroma directly. Flap used to be made with a microtome, but now morely used is a femtosecond laser, and which is more precise. First we will be anesthetizing the cornea, then flap is created with a femtosecond laser to lift the flap to reach the stroma. The stroma is being treated with the X-Siemens laser. Then the treatment changes the shape of the cornea. This flap is repositioned. After the surgery, the cornea regains its new shape. The complications of LASIK includes epithelial ingrowth, deposits in the flap, decentered ablation which can lead to monocular diplopia. It can also lead to sensitivity of light causing photophobia. It can also result in glare and halos, and the most common complications after LASIK seen is a dry eye. Soft contact lenses may be used with post-PRK or LASIK in patients' cases where patient is undercorrected. Always there will be residual amount of refractive error which might need a correction, so soft contact lens can be a better option. For the hyperopic LASIK patients who have residual irregular astigmatism with or without undercorrection, RGP lenses can be a mode of option. This is a typical example of RGP lens fit post LASIK, whereas we can see here central pooling, there is a mid-peripheral mild touch and a thin edge clearance. To summarize, post-refractive surgery management of cornea often involves contact lens fitting to optimize visual acuity and address any residual refractive errors. The evaluation after refractive surgery, the cornea undergoes changes that might require a different approach to contact lens fitting. And depending on the stabilization, depending on the type of refractive surgery such as LASIK or PRK, the cornea may have irregularities or variations in curvature which might need to be corrected with the contact lens as a better option. These are my references. Thank you.